Okay, so we want to go ahead into the, we have the video, right? Yeah.
Hello and welcome to this presentation, Post-Vaccination Visitation Practices. We all know how tremendously challenging and difficult it was when visitation was restricted at the beginning of COVID-19 for the vulnerable population we care for. Now that centers have engaged in COVID-19 vaccination programs, a solid process on opening visitation consistent with guidance and best practice approach for safety is essential for quality of life for our residents, our staff, and ourselves. CDC and CMS, along with state health departments, provide excellent guidance for nursing homes to update their systems.
As Lisa indicated, the Centers for Medicare and Medicaid Services, or CMS, put out revised guidance on visitation, including the impact of COVID-19 vaccination. One of the key definitions includes fully vaccinated, which is important when we look at these key elements of visitation. CMS defines fully vaccinated as a person who is 2 or more weeks following receipt of the second dose in a 2-dose series, or 2 or more weeks following receipt of 1 dose in a single-dose vaccine per the CDC's public health recommendations for vaccinated persons. The key elements that we will be discussing in this presentation include the core elements of principles of COVID-19 infection prevention, outdoor, indoor visitation, indoor visitation during an outbreak, visitor testing and vaccinations, compassionate care visits, and policies and procedures. And when you are developing your policies and procedures, you may want to address your process to include items such as how visitation will occur, if the number of visitors will be limited, designated areas, cleaning and disinfection, and residents in quarantine, and more. Note, for all types of visitation, visitors and residents should be notified about their potential for COVID-19 exposure when they are in the facility.
So we know CMS indicates that the core principles of COVID-19 infection prevention include what you see here on the screen. That's that active screening for all who enter the facility. Hand hygiene, which is the use of alcohol-based hand rub, is preferred. Face coverings and masks, or covering our mouth and nose. Social distancing or physical distancing of at least 6 feet between persons. And really that instructional signage throughout the facility and proper visitor education on COVID-19 signs and symptoms, infection control precautions, and other applicable facility practices. Cleaning and disinfection, as well as appropriate staff use of PPE, effective the cohorting of residents, as well as resident and staff testing that is conducted.
The CMS indicates that outdoor visitation is still the preferred type of visitation because it does present a lower risk of transmission because of that increased space and airflow. Therefore, good planning, communication, and preparation for employees, residents, and visitors will be essential. We have to remember that weather conditions can affect those opportunities for outdoor visitation, and not all residents will be appropriate for outdoor visits due to their medical conditions. Some families may be willing to be outside when other families may not. Discussions around preferences will need to be considered as well as planned for. Good documentation is essential. A safe spot with tents, patios, other outdoor areas can be a great place for residents to enjoy visitation.
We also know that facilities should allow indoor visitation at all times for all residents, regardless of vaccination status, except for a few circumstances when visitation should be limited due to high risk of COVID-19 transmission, as you can see here on the slide. So CDC indicates that ideally, unvaccinated residents who wish to be vaccinated should not start indoor visitation unless they've been fully vaccinated, and before allowing indoor visitation, explain the risk associated with visitation to both residents and their visitors.
CMS indicates that compassionate care visits and visits required under federal disability rights law should be allowed at all times, regardless of a resident's vaccination status, the county's COVID-19 positivity rate, or an outbreak. While end-of-life situations have been used as examples of compassionate care situations, the term compassionate care situations does not exclusively refer to end-of-life situations. And if the resident is fully vaccinated, they can also choose to have close contact, including touch, with their visitor while wearing a well-fitting face mask and performing hand hygiene both before and after. Having those good systems and good employee education will be essential in order to be able to have a process for successful compassionate care visits that are consistent with best practices for infection prevention and control, for safety, as well as for quality of life and regulatory compliance.
So as a facility, you can consider the number of visitors for each resident at a time and the total number of visitors you can accommodate in that facility in order to maintain the core principles of COVID-19 infection prevention and control. Visitor movement within the facility should be limited, and good visitor communication is very, very important. If the resident has a roommate, the visit should not be held in the resident room unless the resident condition prevents the resident from leaving. So in this case, good visitor communication and oversight on those core principles of infection prevention and control is essential. And it will be important to have a good process in place to really plan designated visitation areas. And that's important with good staff education and communication. So indoor visitation, we need to also consider during an outbreak can still occur, but under certain guidance. And when there is evidence that transmission is contained to a single area of the facility and outbreak testing identifies no additional COVID-19 cases in other areas. So if one or more additional COVID-19 cases in other areas of the facility are identified, then visitation should be suspended until the facility meets criterion to discontinue outbreak testing.
It will be essential that with updated guidance and best practices, that the policies and procedures capture those updates. Then education will be essential for employees, visitors, residents, families, and even volunteers to include screening, risk, and visitation specifics such as location, timeframes, number of visitors. A process for monitoring and oversight will also be instrumental to identify if staff, residents, and visitor practices are consistent with those policies and procedures. And lastly, it is essential to remember the importance of quality improvement. Including everyone in quality improvement process will be essential to identify a good root cause analysis of any opportunities for improvement, as well as to work together as a team to identify solutions for quality and safety.
And as you can see here on the slide, we wanted to share a quick little kind of visual diagram of really that process about visitation and indoor visitation. And this is a great picture that you can use and you can fill in for your organization that really would really align with the key components that are outlined in the CMS QSO memo 20-39-NH, which was revised recently, that addresses visitor guidance, including the impact of COVID-19 vaccination. So regardless of how visits are conducted, you need to follow core principles of COVID-19 infection prevention, such as the screening, hand hygiene, face covering, physical distancing, and all those other elements that we discussed here today. So please note that when CMS talks about fully vaccinated resident, that means a person who is 2 weeks or more following the receipt of a 2-dose or single dose per CDC recommendations. So again, in summary of this module here, visitation is essential for the emotional and psychosocial needs of our residents as well as our staff. This visitation must be planned, organized, and implemented in accordance with current state and federal and local guidance and best practices. Ongoing education is essential for our residents, employees, and visitors, and it's also a key component for success. So again, visitation is part of our post-vaccination processes and practices for nursing homes. We want to thank you again for attending this presentation.
Great, thank you for that. So one of the points is that we send the slide deck out for this presentation. If you want to copy and paste that algorithm for visitation and put that in your policy book, that probably would be a pretty good idea. I mean, you can obviously modify it in whatever direction that you want, but those, use the tools here while you got them and help update your policies, with these tools. Michelle, you want to take over?
Sure. Yep. We are on step 7 out of the QAPI at a glance, and we're starting with that data element. It's really crucial that organizations effectively identify, collect, and use data and information from all departments and that facility assessment. You want to identify data sources, the frequency of data collection and analysis, establish your targets and benchmarks that you are going to use, and establish a plan to communicate the data analysis. Choose data sources your organization will use to develop and monitor performance indicators that will track your ongoing performance. And I just can't help but stress, this is not just the job of the QAPI coordinator or the DON. Anyone can help with collecting data, which is basically what Kelly was just saying a little bit before. Any team can analyze their data and decide on whether we need to start an improvement effort. Next slide. And so this is actually just a graphic that I pulled out of our GP Quinn QAPI how-to guide, how to write your QAPI plan. And I like, how this just pulls the elements of what is good data collection. So how often you're going to, first thing is your data source, where you're getting it from, but then also how often you're going to collect it, what benchmarks you're going to use to analyze your data, who's going to do the analyzing, how frequently, who you're going to communicate that with, and how often you're going to communicate that. So there's just a link there for that. It's a good tool or a good definition of it. Next slide. Excuse me. The next slide is sorry. Excuse me. I've got to frog. Is actually from the CMS QAPI website, where they have just a plethora of QAPI tools. This is another one. We've been sharing a lot of them as we've gone through. Jean's put a whole bunch of them in that chat. This is the Measure, Indicator, Collection, and Monitoring Plan. This is just, I pulled out just a screenshot of one element, one area of it that you can use if you're wanting to. I wouldn't use this over and over again, but it's as a starting place to kind of help you build what your plan is going to be. And this is very similar to that last screen. What are we measuring? When? What's the frequency? How do we measure it? Who's responsible? What is our goal or our aim or our benchmark that we're trying to hit? And how will the findings be shared? All right, next slide. This is just a huge list of suggested data sources. I threw all of these on here because there is so much data available for nursing homes. Certainly, please do not go out and try and grab all of these things. I just wanted to, give you a starting place, maybe taking a look at what are some things that we want to be tracking and looking at. We're going to go into more details regarding data use next week. All right, and next slide is just something I wanted to highlight. In looking at some of the homework that's been sent in, I wanted to just pull out the fact that when you're looking at where your data is and where you're starting at and what you're trying to improve from, this is an example of the Casper facility level quality measure report. And what you want to look at is your numbers, your observed percentage, or it could be your adjusted percentage, but these are your numbers. This is your numerator divided by your denominator to get to that observed percent. I've seen a handful of folks that are putting in that last column as their percentage that they're trying to work on. And you can't make a whole lot of impact on this. This is comparing you to every other facility in the 15,000 facilities in the country. This is just where you land on that percentile. I love that people are looking at this because, if it's starred, that means that you should be working on it. It's something that survey is going to be looking at when they come in. it basically means it stars at 75%. And that means that 75% of the nursing homes in the country are doing better than your facility. So it's a good area to look at and identify what you want to work on. But when you're actually putting in the data of what we want to improve on, we want to look at our own facility percentage just for this Casper report. And we've started getting some videos up on our website to help with the quality measures. We've only got 3 so far, but one of them is understanding your Casper report I put the link for here, and Jean put in the chat, but it goes through the elements of that report and also give you some tips on how to use it for QAPI. So next slide. And we'll go right on to the next one. The facility sharing with us today is Missouri Slope in Bismarck. And I saw April was on. So we're just going to have her kind of go through some of the elements of their PIP. And April did mention in the chat that she has shared her form and is willing to share that with everybody else. I am gratefully appreciative of the fact she was willing to trial it in our template just to kind of keep some consistency going as we share each week. But you'll see it's a little arduous how she put it in there because they have been doing things a little bit different, but we'll go through that. April, are you on?
Unmute. It's April.
Hi.
Hi. So yeah, we talked earlier this week, and I talked about the format and everything, and I'm like, I don't know if this should go here, but I'm putting it there. So I'm just like, yeah. And honestly, the PIP squad members are members of different PIPs that are all associated with the same situation. So we actually had, I want to say 5 different PIPs that related to this same thing that we were going for here. So they're all kind of intertwined, and they're all going at their own paces in different departments. So they're already kind of out there and running, as you will, but I tried to put them together to show how it relates here. We've actually been working on these for a lot longer than 225 of 21, but I honestly don't know how far it goes back. So we incorporated resident loneliness, the tool that we had used for this group, and then we pulled out isolation of residents because that's where we found most residents had answered yes to and marked high in that area, is that they feel isolated. So the goal is not only to improve isolation and loneliness, but resident behaviors, and behaviors are directly related to isolation and loneliness because they're bored. And as you know, a lot of residents in long-term care have some form of Alzheimer's. So providing better care to the residents and creating a more pleasurable workplace and living environment will improve all areas, basically.
Great, and thank you, April. Though I just wanted to mention one element on here that when we're writing up the goal, we encourage people as part of the science of improvement to make it a SMART goal. And so a couple things that I would encourage you to add to your goal is, what are we actually going to measure? And we get to that later on in your document. And so maybe it's not important to have it written a couple of places, but what are you measuring? Are you measuring that behavior QM? Are you measuring that loneliness score? And then having a timeline so that you know that we need to get back together and look at this by this date. If it doesn't happen, we at least have a notation that we were going to get together today and we need to reschedule so that we have some definitive time so it doesn't just go on a pile and get forgotten. So we can go to the next slide, which is just the pretty bare minimum of what you sent in for your root causes. But on the next slide, you have a ton of root causes.
Right, we didn't use that tool, as you will, for our root cause analysis. We had a different form that we had used, so.
That's fine. That's well, let's just skip by it.
Right, so we talk about a lot of different things in this root cause because we were originally talking about improving resident behaviors. So we looked at a lot of different issues and branched off, and we meet for different issues at different times. So we have monthly meetings for our QM report. We have weekly meetings for our behaviors. We have monthly meetings for our psychotropic medications. You know, so everything is running at different paces, but they all work together to reach the same goal. So I don't know how to write that down on paper, but that's what's going on here. So we know that our charting options weren't adequate. So the charting options were changed in our way of charting as point click care in March of 2021. So the staff can chart several things instead of just one, interventions and things like that. And the way that the charting is, and now the nurses can use the CNA's charting in their documentation as well. So that's helped as far as seeing which residents are having more issues anyway. HealthStream is our training database that we use for all of our online training. And unfortunately this year, HealthStream went to a new platform as how they do their videos and such. And they are still working on getting more things available to us. And so HealthStreams, because they changed, they're not as good of teaching tools as we've had in the past. So we can either make our own, which is what we've been working on, or we can wait for them to update theirs. But we know that theirs are getting updated monthly, so we do incorporate theirs if we can. Does that make sense?
Yep, yeah.
So communication books, we had talked about, it's something that we use on our units at our facility. And they just kind of, you know, maybe describe a resident's behavior, what happened today, and then they might say what worked and what not to do. And then in report, you know, the next group would come in and read the communication book and see, okay, what happened, with a little bit more detail than the progress notes sometimes, and maybe something that didn't work that isn't always charted. So you can also look back a few days or whatever, but our Alzheimer's unit uses their communication book religiously. So they're very detailed in their what they pass on for the next team coming on. And we haven't started working on that issue as of yet. We looked at the books, we said, yeah, they could be utilized better, and then it just got simmered on the back burner for now. Virtual dementia training is something that we looked at using, but prior to COVID, and we had everything ready for it, and then we didn't do it because the pandemic hit. But we came back together as a team in our PIP, and we set up the skills lab for all the direct care staff, and we set up the dementia training simulator. The first team goes through the simulator tomorrow, and so then we have to get all of our staff through it, and that's going to take us a couple of months. So this part of that PIP will be going on for at least 2 months, if not 3. And that's why, as far as this PIP goes, each thing kind of has to run at its own pace. So we also did CPI training prior to COVID. I don't know, just one of you guys want to explain CPI training? Do you guys know what I'm talking about?
I believe that is for working with if they're more aggressive.
Yeah, it is, but it's also, it teaches you maybe how to different approaches,
like
right?
verbal de-escalation,
Awesome.
to stop it so that things don't escalate and so that you have those physical behaviors.
right, most of the time physical behaviors are a cause because of us, something that we did, not something that the resident did, and something that we did agitated them to the point where they acted out. And so we're trying to prevent that from happening. But CPI training is a very hands-on course, and you can only have a few people at a time. And during COVID, we were unable to have those CPI trainings, but we did have that prior, and we hope to have it again. But we do have 2 trainers in-house that are trained to do CPI training. So
It stands for Crisis Prevention Intervention, I think.
is that right, Tara? Yeah. Yes.
So April, I'm going to just stop you right there. Part of what I wanted to just kind of highlight in, you have got so many projects going on. And one of the things that we're trying to kind of teach is, taking smaller chunks when you're actually looking at improving some of these things. And so I know that you've got this on different formats, and it maybe works better on that than what we tried to cram all into here. But I would encourage you, if you're looking at, tracking it, just take a smaller portion of this. That communications books as a project, I love that idea. And what we're looking at is the individual elements that you need to make sure are happening. So we start very small. We're going to start with the communication books on, 1 unit, and maybe only, 4 or 5 of those. And how do we go about updating those and putting those steps into your PDSA? So whose responsibility is it to contact the family and make sure that this is up to date? How are we going to educate our staff on what we want involved in those communication books? And then, and then how do we get them out there? And how do we make sure that people are utilizing them? Just those little tiny elements that it might be too much to write down on here, but that's really what this kind of document is for, is to, sometimes we need to break them down like that so that we don't miss anything. And then that's when we find out that, oh, this didn't work. It didn't work to have Angela reaching out to all the family members because she didn't work with her schedule, or she was offensive to the, and we adapt. And how are we going to do that next? So I'm not going to have you go through all of this. We'll go to the next slide. And you've got a lot of these elements in here, the loneliness questionnaire. I'm glad you guys are working on the virtual dementia training. You've just got a lot of stuff that you are starting and are monitoring. And
yeah, you got to remember too that these are separate PIPs all working at the same time. And so, I mean, they all are on this one document, but like the loneliness questionnaire PIP is its own PIP. The virtual dementia training is its own, and the infection control procedures. So that's why I was like, I just didn't really know what you wanted on here. But as far as everything working in its own pace is part of the issue with the homework, is like, I won't have another update for the loneliness questionnaire for at least a month, because we won't be, so I was trying to show you that we are working on QAPI in several different areas that, is trying to reach the same goal, and going from there. So we have everything going in its own, really, and it's just all in this one document for this meeting, I guess.
Yep. And thank you so much for sharing that. And so, as far as that loneliness questionnaire, after you've done that, part of the, the do and act is, what kind of interventions are we going to be implementing with the activities, and starting that small. You guys only did it on 18. And so working with those 18 or even fewer, and seeing, and trying some of those interventions and putting that down, that we're going to do this, and then we evaluate if that worked. We'll go to the next slide. And I just made, this is some of your data. We'll just go to the next one, where I just pulled out a few, this for tracking on this one document, some of those things that were related to potentially your UCLA one, because you're also looking at depression on the PHQ-9. This is where we're pulling that data in, where the PDSA, we're actually looking at, implementing those small steps. And this is where we can track our data that we can see if we need to change, or and that's where we can share with the QAPI team and with your board and all of those things. So I just put a few suggestions in here for how to track that. And in the comments, are we seeing improvements with this as we go first measurement, second measurement? This is just my examples and my data that I threw in there. So I want to thank you so much, April, for sharing everything that you have. Anything else that you'd like to share about the efforts that you're making, or how you work QAPI into your daily work?
I guess it's just getting everything down on paper is the hardest part. It's all going at once, and I did use a tool very similar to this one, and I think I got it from you guys for all the things that we're doing in infection control. And infection control is taking, I don't know what word I'm looking for. Infection control is just, well, it's a lot of time, but it's the most important thing going on right now. So
Priority.
Yeah, taking priority, and that and getting people vaccinated. So, our vaccination PIP meets weekly, and it's an hour every week. And then, going back, and everybody has their things going on there. So coming back to this is somewhat difficult when you have all that other stuff going on too.
So totally understand. And again, appreciate you putting in this extra effort to share with the group. And hopefully this might help, other facilities if they're struggling with that. So thank you so much, April. And we'll get on to the next thing, so we don't waste any more time than our hour.
Oh, can I add, Michelle, do you mind backing up to that previous slide? That I had a comment there. So if you look at, 1, 2, 3, the third one down, behavior affecting others. So that opens up a whole world of possibilities as to what evidence-based interventions might occur. And so, we heard that training, virtual dementia training, for example, maybe one thing. And so you'll implement that in that particular month, and then measure to see if the behavior has reduced. From a geriatrician's point of view, I'm aware of what we call empiric pain treatment for agitation with demented patients. And so actually a British study indicated that if you used empiric Tylenol for somebody that had agitation, that they were able to reduce the agitation rate by over 10%. So that would have an impact also. And that might be something that, if it worked, then you could have a standing order policy from the medical director that says anybody that's agitated, trial of 2 extra strength Tylenol, if not contraindicated, for treatment, and reevaluate. So yeah, there's a lot of options here, and I, and I'll just, not that I'm the expert at everything, but when I see these things come up, my wheels start turning, and I'll give you feedback on, evidence-based medicine as best I know it, to help improve your programs.